recording, and I'm gonna have us go live, I think. Let's see. Okay. So I think, yeah, we can get started. Welcome, everyone. Thank you so much for joining us. I'm really excited for this conversation today. My name is Alice. My pronouns are she, her. I'm part of the NYC-DSA Healthcare Working Group. And this is part of our Week of Action for the New York Health Act. So the event tonight is a teach-in and panel on the intersections of health justice and racial justice, how we can use the New York Health Act to promote goals of racial justice, and how we need to kind of focus our organizing in health justice and in socialist organizing more generally around anti-racism. So we have a really excellent panel of speakers today, so I'm going to try not to talk for too long because I'm really excited to hear from all of them. But I'm going to get started by just giving a quick introduction to the New York Health Act and to a little bit of the work that the NYC-DSA Healthcare Working Group is doing related to hospital closures in New York, which are there's been a major issue of racism and a pattern of hospital closures that have happened here. So I'm going to speak a little bit to that, and then I'll introduce our speakers, and we can talk a little bit more about some of the other topics that they are the experts on. So I'm going to get started just by sharing my screen in just a second. Sorry, just one moment. Okay. So let's see, sorry. Can people see the PowerPoint, or are you seeing my entire screen?
We're seeing Chrome with the presentation, but it's not in presentation mode.
Okay, great. Sorry, just one second. Okay, I'm having major issues with
Do you want to send it to me and I can screen share, Alice?
Okay, I think I can do this. Is it now in the presentation mode?
Perfect.
Awesome. Thank you, Ivan. Sorry, everybody. Okay. Yeah, so I just wanted to give a quick introduction to the New York Health Act, because that is what our Week of Action is revolving around. So the New York Health Act would basically be a single payer bill that would cover everyone in New York. It would be comprehensive health coverage. So every single New York resident and everyone who lives or who works in New York and lives elsewhere would be part of this New York Health Plan. And it would cover all medically necessary services. So, you know, that includes long-term care, dental, mental health care, gender-affirming care, things that are often not covered by commercial insurance or the way like current public insurance. It would eliminate private insurance in as much as it duplicates what the New York Health Act covers. So there'd be very limited room for any kind of private health insurance, and there would be no network restrictions. So in that sense, it would eliminate this tiered system of healthcare that we currently have, in which certain providers accept only commercial insurance, other providers accept Medicare, Medicaid. Some providers will see people who are uninsured, but at this point, I think we have this like tiered system, and the New York Health Act would eliminate that because everyone would have the same health coverage. And ultimately, medical decisions would be made between a patient and a doctor. So an insurer doesn't have a say in patient care anymore under the New York Health Act. There isn't someone who makes money off of you not getting the care that you need to get, telling you, oh, I don't think you need to get that care. And there would just be zero costs at the point of service. So you're never, walking away from the pharmacy without your medication because you couldn't afford it. You're never skipping a doctor's appointment because you can't afford it. It would save costs for New York. So at the moment, because in our current healthcare system, there's this huge amount of money that just goes towards administrative costs, towards billing, towards stuff like that. And since we have all of these different payers, the New York Health Act, both by eliminating many of the administrative costs and by having the purchasing power of this one kind of giant healthcare buyer, would massively save costs. And basically it would get paid for no longer by, people paying different amounts into premiums. It's kind of, at the moment, healthcare looks like a regressive tax because everyone has to pay for it. But, people who make less money are paying a much larger portion of their income towards it. Under the New York Health Act, it would be through a payroll tax and a tax on non-payroll income. And it would, you would pay more depending if you make more money. So it would be a progressive tax. And there would be, as I said, no premiums, no deductible, no cost sharing. And 90% of New Yorkers and most employers who pay into health insurance plans would pay less under the New York Health Act than they're currently paying for healthcare costs. So that's what the New York Health Act is. That's what we're fighting for. Right now, it has a majority of support in both the Senate and the Assembly. Today, we had a digital day of action that I know plenty of people here participated in to call on Carl Hastie and Andrea Stewart-Cousins to actually bring that up for a vote this year. We have the votes that we need to pass this really major important legislation, and we just need to make sure that it happens this year. So if you haven't gotten a chance yet to call Carl Hastie and Andrea Stewart-Cousins, I would love for you to do that. We can send that information as well. So I also just wanted to talk about hospital closures in New York, because this is something that the Healthcare Working Group has been working on a little bit this year, because it's a major problem both in terms of health justice and racial justice. I think this is one of the places that we've seen this come together, and one of the areas we've been able to work on this as like a dual issue. Basically, over the last 20 years, New York State has lost over 20,000 hospital beds. There are a lot of reasons that this happens. Like hospitals, it's expensive to be prepared to give a lot of complex care to a lot of people. It's also completely necessary to be prepared to do that. I think Katie Season is going to be speaking a little bit later, and I've heard her explain all of this much better than I ever can, so I'm not going to go too into the weeds with it. But some of the reasons here are that low Medicaid reimbursement and inequitable distribution of funds that are intended to pay for uninsured or underinsured patients, those create this inequity in which hospitals that give care to people with lower incomes are less able to keep functioning. And in a lot of cases, that means that those hospitals get consolidated with other hospitals, those get closed. We now have these giant hospital systems that own most of the hospitals that people are able to go to, and they do everything they can to avoid seeing people who don't have expensive health coverage. So what we see a lot of the time then is that hospitals will close in low-income, majority Black neighborhoods, and they're replaced with luxury and unaffordable housing. So the impacts of this can be really devastating. It means that people have to travel to get care. They have to travel farther. Physicians often leave communities once the hospitals aren't there. And we see this situation in which, some people will go to a new hospital, but up to 30% of people just kind of disappear. People who were receiving treatment and care aren't getting care that they need anymore, because they don't have access to services anymore. And so that's a huge devastating impact. It means that people aren't getting necessary preventive care that they need, aren't getting necessary treatment. And we've seen it happen, particularly in New York. And this was something that at the start of the COVID pandemic, this is a major problem. We had half as many hospital beds as we needed in New York. We all of our hospitals were, really understaffed. And what it meant is that in neighborhoods where hospitals closed, oftentimes those were the same exact neighborhoods with really high rates of COVID infection and COVID death. And so, and if this is happening, if consistently we're seeing hospitals closing in majority Black neighborhoods, and then those are the same neighborhoods that have these like really high rates, there's definitely a correlation there. There's a lot of other stuff that was going on as well, as to why Black communities and communities of color were disproportionately impacted by COVID, but that certainly played a role. And so we're actually seeing this play out right now in East Flatbush. So Kingsbrook Jewish Medical Center is a safety net hospital in Flatbush. So a safety net hospital meaning that it must serve people regardless of their ability to pay. And it was scheduled to close, eliminating 200 inpatient hospital beds. It actually originally was supposed to close last spring, and then the COVID pandemic happened. So of course you can't close a hospital, except then they said, okay, so we'll close it in December instead. Obviously, we were still in the middle of a pandemic because of a lot of work being done by community organizers, by people who worked in the hospital and lived near the hospital. It was postponed. Again, we recently heard, okay, May 1st, this is it. We've waited long enough to close this hospital, completely against any kind of reasoning you might have, because we're still in the middle of a pandemic. But at this point, yeah, there's been a postponement of the closure, but not a cancellation. And so it's still kind of moving forward. So at the moment, the Healthcare Working Group is working with people who live in East Flatbush, people who work at the hospital or, have worked at the hospital, work near the hospital, and other activists. And the idea is to stop Cuomo from closing this hospital. So this is kind of like just a case study and like the exact way that this continually happens. We're being told this is a transformation. This is like for public health. This is because we want to get affordable housing. Ultimately, what it is it's just a removal of necessary services from a neighborhood that is, already has like a fairly low density of hospital beds. So I say all that, and there's that QR code there where you can sign the petition and get involved with the fight to stop the closure of Kingsbrook. But so that is kind of my piece. And so I will go ahead and, sorry, one moment. So yeah, so that's what the New York City DSA Healthcare Working Group is working on at the moment. And I'm gonna go ahead and pass it along to our next speaker. So our next speaker is Katie Season. She's a midwife, a doula, and a nurse who worked in the neonatal intensive care unit from 2014 to 2019 at SUNY Downstate, which is a state-run, segregated, Black, and intentionally underfunded hospital in East Flatbush. She's now a full-time activist organizing birth workers and birthing people to work on legislation addressing medical racism and misogyny. She started the campaign Equity for Downstate, which was instrumental in securing an additional $50 million in funding for the hospital in the 2020 to 2021 New York State budget. And she is working in a coalition to help pass the New York Health Act. Katie, please take it away.
Alice, thank you so much for that introduction. Hi, everybody. My name is Katie Season. I use she, her pronouns. Yeah, and I'm excited to be here today sharing with you guys a lot of what I have been learning in my journey as a nurse whistleblower, trying to bring attention to the very dangerous patient care conditions at SUNY Downstate Medical Center and other predominantly Black serving hospitals in central Brooklyn, and what the policy solutions are for us to actually address those issues and to arrive at a place where we can be providing quality of health care to everybody who wants and needs it. So let me share my screen for my slides. And I'll just put in the chat, sorry. As Alice said, I work mostly with organizing birth workers and birthing people. And one of the main ways that we do that is by helping connect people who are in the same legislative district. So if So even if you're like deep in the DSA and organized mostly with the DSA, please fill out that form so we can help connect you with other birth workers in your district who may not be as politically active, to create these strong district-specific coalitions to help advance these policies. But I want to talk a little bit today about, we're talking about racial health disparities and private public health insurance, specifically in the context of the afterlife of slavery. And as we talk about racial health disparities, I think it's really important to clarify that it is racism and not race that causes racial health disparities. So what that essentially means is like there is nothing wrong with people with darker skin or with people of African ancestry. There's nothing wrong genetically. There's nothing wrong with their bodies or with their biology that would make that population more susceptible to worse birth outcomes. Where there is something terribly wrong is how our society has always currently and has treated people with Black skin and of African ancestry since the origin of our nation in an unbroken chain till today. And so in that discussion, thinking like it's racism and not race that causes racial health disparities, I want to help frame the conversation about private public health insurance as like private public health insurance is structural racism. And so if we want to eliminate racial health disparities, it's not the only thing we have to do by any means, but one important and really the first step we can take and should be taking to undoing the disparities that we've created is by ending this separate and unequal system of private and public health insurance. And talking about racial health disparity, when I say like we've always been this way, I think this is why it's important to frame this conversation in the narrative of the afterlife of slavery, which is a framework originated by Dr. Saidiya Hartman to describe the enduring presence that slavery's racialized violence still holds in contemporary society. And that's particularly important in my field of infant and maternal health because racial disparities in infant maternal health outcomes are worse today than they were when chattel slavery was legal and going on in America. So in 1850, which is the first year we collected data on infant mortality by race, the racial disparity in infant mortality was 1 to 1.5, and now it's 1 to 3.3 in New York City. The way that structural racism has manifested itself has changed, but for sure, there's still definitely something terribly wrong in our society that these disparities have only grown with time. So looking specifically at New York City has the worst racial health disparities of any geographic location in America. And the last data we have of racial disparities in maternal mortality showed a 1 to 12 ratio. Guys, like that doesn't exist anywhere else in health. Like if you go to nursing school or medical school, you'll learn like, there's, this population is 20% more likely. They're 50% more likely. They're twice as likely. Wow, that's a lot. 12 times, this doesn't happen. This doesn't happen other places. This doesn't, like in health, this doesn't happen other places geographically. So what is, and also I think important to realize the data is 11 years old because the entire time Cuomo's been governor, he hasn't given us new data. So what is going on here that our disparities are getting worse, and in New York City is particularly bad, is that we have our private public health insurance system. The private insurance pays about twice as much as what public insurance pays for obstetric care, and that pattern continues in almost any other realm of healthcare. And so what happens is when you have a hospital that serves a disproportionate number of people on public insurance, that hospital is going to take in half as much money as a hospital that serves predominantly people on private insurance. And then like it shouldn't be, but is necessary for me to say, like, and if you pay a hospital half as much as another hospital, you're going to have worse outcomes. And if most people who receive care at that hospital are Black, the worst outcomes that happen because the hospital itself is dangerous will ripple out to create population level health disparities. So what we see, what we have here is a map of the 10 hospitals in Brooklyn that have maternity services ranked from safest to most dangerous, and then plotted on a map that shows the racial and ethnic distribution of Brooklyn. And what we can see is that the 3 most dangerous hospitals are straight in the center of segregated Black Brooklyn. And they're not more dangerous by a little bit. They're 6, 7, and 8 times more dangerous than the safest hospital in Brooklyn. And if you're thinking, okay, well, I'm looking at your map, Katie, and what I also know is no one lives more than 10 miles away from that safe hospital. Why don't people just, knowing this data, go and get care at the safer hospitals? Well, because the safer hospitals actively practice insurance segregation. So you'll call with your insurance card that you're on public insurance and say, like, hey, I'm looking to establish prenatal care. And they'll either tell you, sorry, no provider here is currently accepting that insurance, or none of our providers who accept that insurance currently have any space on their roster. Or they will refer you to a student-run clinic, essentially, where if you call with private insurance, they send you straight to like a full faculty professor. And if you're thinking, that doesn't sound right, we shouldn't be able to discriminate or segregate based off of insurance status, you're right. It breaks 2 national, 2 state, and 1 local law to do so. But laws don't matter if we won't uphold them. And in 2011, when the New York Lawyers for Public Interest brought a lawsuit against the private hospitals for practicing insurance discrimination, the Attorney General of the state of New York at the time said, nah, not worth prosecuting, no big deal. Who was the Attorney General? Governor Cuomo, who went on to become our governor. And so the private hospitals for the past decade have been practicing this unchallenged, very blatantly and openly. Almost anyone who works in healthcare knows that they're doing this. Like, we hear the administration talking about how we don't take Medicaid clients or how we send them to a different clinic. And like, we can't do anything about it if the people who hold power in our society don't want to. So I just want to pause here and say all of the problems I've described so far get solved when we pass the New York Health Act. Like, the difference between the the difference in the amount of money that hospitals take in because of who their population serves, there won't be a difference once we're all on the same health insurance. And also, like, what private hospitals are currently doing, or safer hospitals can deny care based off of insurance status, they won't be able to do that anymore either, because again, we'll all be on the same insurance plan. So I should be able to stop my presentation here, but it gets worse. And I guess that's kind of underlying racial health disparities anywhere in America, is this difference between private public health insurance. Why is New York and New York City so much worse than other places? Well, Medicaid knows that the program is inequitable, and so they have a separate pool of money called the disproportionate share hospital pool, and that's supposed to go to hospitals that serve a disproportionate share of people on public insurance. And so, given what I've said now, you're thinking, oh, great, so those public hospitals taking all of the patients on public insurance because the private hospitals discriminated against them, at least they're getting their money now. No, they aren't, because the 49 other states distribute the money the way that it's intended to. 49 other states predominantly get this money from the federal government and use it to pay the hospitals that actually serve a disproportionate number of people on public insurance. In New York, because of government corruption, they wrote a law that separates that federal funding into two pools, one for the private hospitals to divide into, and the other one for the public hospitals to divide into. So what you can see here is these blue bars show how much money the hospitals are spending on un- and underinsured care, and the orange dots show how much money they're getting back from Albany. So the public hospitals are racking up hundreds of millions or tens of millions of dollars of debt, while the private hospitals just get free money to do whatever they want with, and mostly it's very like excessive compensation to their executives, not reinvesting it to improve the quality of care that the patients at the private hospitals receive, or doing something like, I don't know, preparing for a respiratory pandemic. So in 2016, the same year that 80% Black serving Kings County Hospital lost $80 million, Albany gave $17 million of free money to segregating white New York University Hospital. So again, like, this is when I first learned about that, I was like, oh my God, we need to change that law that changes how the DSH money is distributed. And then I was like, no, we just need to pass the New York Health Act, because all of that, like all of those opportunities for inequity to come into our public health policy, again, go away once we're on a universal single payer health plan. It was the, I think I went through this slide quickly, but it was the Segregated White American Medical Association who, the first time they ever collected dues from their membership was in the 1960s to fight going on single payer, because white doctors who saw the end of racial discrimination didn't want to take care of Black people, and knew that by creating a private public system, they could continue to segregate by using insurance as a proxy. And so by going to a single payer system, we eliminate the insurance programs that essentially that recreate the hierarchy of human life that was created during slavery to justify slavery, and we've never yet addressed. So thank you so much for inviting me to speak today. I'll again say, please come organize with me and fill out that form, and I'll help plug you in or plug other people into the work that you are doing in your districts. Yeah, let's pass the New York Health Act.
Thank you so much, Katie. Really appreciate it. Yeah, and so yeah, definitely fill out Katie's form. She runs an amazing group called the Movement to Birth Liberation, and very excellent meetings for that. So next I'm gonna invite our next speaker, Lauren Wilkinson. She's a member of the Racial Justice Working Group's organizing committee. And when she's not organizing with the DSA, she's a screenwriter and novelist whose first book was a Washington Post bestseller and on Barack Obama's recommended reading list. Lauren's gonna talk about a perspective on reproductive justice, and also about the work that the Racial Justice Working Group and Defund campaign are doing.
Yeah, thank you so much, Alice, for having me speak here. And thank you, Katie, for that very sobering breakdown. I also, when Alice and I first started talking about this event, I realized that I don't have really a healthcare background, but just like as a patient, as somebody who has grown up in New York, I do have, as a person who wants to get pregnant within the next few months, and I'm aware of all of these things. It's really, it's quite frightening, like just as a person who is looking at all of these statistics, it's really scary. I know that, I'm sure that everyone in this room is aware of, there was like a study in 2016 that concluded that Black patients are systematically undertreated for pain, and that this is linked to the fact that 70% of white medical students surveyed believe that there were like actual biological differences between races. The big example being that a number of these students believe that Black people can bear pain better. This disparity in pain treatment is apparently true even with kids. A study of nearly 1 million children diagnosed with appendicitis revealed that relative to white children who were patients, Black patients, children were less likely to receive any pain medication and were less likely to receive opioids, the appropriate treatment for such horrible pain. This is a type of violence, you know, and it's a very quiet one, and it's a very, very difficult one to root out, but the consequences are profoundly dangerous. They're dangerous for me. They're dangerous for like a flesh and blood person, you know, that's sitting here and talking to you now. So I just wanted to add, you know, that viewpoint as well, just as a person and as a patient. You know, I'm scared, but moving on to, so as Alice said, my name is Lauren and I'm from the Racial Justice Working Group. So our big campaign is, of course, the Defund campaign. Our working group's research committee has been working really, really hard to develop our policy plank, which they released just yesterday, and it is fantastic. It's called The People's Budget NYC, and before I start talking, I just want to acknowledge the effort and the dedication that the committee put into this excellent resource. I'll definitely put a link to the budget in the chat later, because I do think it's really worth, you know, even if this isn't, if you don't think this is your interest or area of focus, it's just worth seeing how much money we're talking about that goes to the police, and how, you know, that could be so much better, you know, just distributed throughout the city to services like healthcare. So yeah. So as I'm, you know, said, I'm a layman. So when I think of the city's police department, I like to think of a giant octopus that has its tentacles reaching out into every corner of New York. That's an image that helps me understand the essence of both the NYPD and the police union. They are extremely powerful organizations, and they only gain more power by using those tentacles to leech money from the budgets of smaller departments, which explains some of the nonsensical policies that we have in this city that we accept as normal, but are actually totally irrational. For example, why should outreach to people who are houseless fall to the NYPD? What possible resources do cops have to offer? It makes no sense until you realize that the existence of the NYPD's homeless outreach unit means hundreds of millions of dollars that rightfully should have gone to DHS, to the Department of Homeless Services, can now go to the police. One of the things that made me realize that we live in a police state is that cops are offered as a solution to everything. It's a knee-jerk response at this point, and it's not a rational one. Another example, police officers should never be the first responders to a person who is suffering a mental health crisis. They're not mental health professionals by any stretch of the imagination. Only about a third of the cops in this city have any kind of training regarding what they refer to as EDPs, or emotionally disturbed persons. That's the phraseology now. But even if that number were at 100% of them were trained, it wouldn't matter. You can't train or reform away the fundamental function of cops. And their fundamental function isn't mental health care. So, you know, cops in poor neighborhoods and predominantly Black neighborhoods field a disproportionate amount of 911 calls that eventually lead to an individual being taken in for psychiatric hospitalization. Between 2017 and 2019, 14 of these calls resulted in the person who was in crisis being killed by the police who'd been called in ostensibly to help them. The majority of mental health crisis-related 911 calls see cops bringing the person to the ER, which isn't necessarily a productive setting for a person in crisis. In fact, the only setting that I can think of that would be worse is jail. And of course, that's also where a lot of people in crisis end up as well. New Yorkers who are in crisis are being cycled through hospitals, through the criminal justice system, and then right back onto the streets. And this is an ass-backwards approach where there's no room for early intervention. We let people hit a crisis point, and then we call in cops to make it all go away and to clean up the mess. The NYPD budget is $11 billion. $6 billion of it is operational, and $5 billion is spent on everything else, pensions and benefits and what have you. As the People's Budget lays out so clearly, the Defund campaign has a core demand for the City Council. We want them to cut the NYPD budget by at least $3 billion. We want to see that surplus money go to services, and real public safety, because real public safety means that all New Yorkers have their basic needs met. So we need to invest in robust public health and community services, like the New York Health Act, healthcare, economic and food security programs. And at the Defund campaign, we are also advocates for a community model of crisis intervention and prevention, one in which health advocates and activists should be instrumental in shaping. I can envision a world in which there was another number, something other than 911, that directly connected to mental health providers, people who could actually help someone experiencing a mental health crisis or a chemical dependency issue. I can also envision a world in which enough intervention happens early enough in a person's life that they never get to a crisis point. To me, the prospect of defunding the police opens the door to imagining better ways to care for each other. And in that way, I think defund means enlarging the scope of what is possible for our city and for our future. Right. That's it. That's all I have to say. Thank you, everybody, for listening to me. Now,
thank you so much, Lauren.
Brandon.
Thank you. Yeah, I really appreciate that, and absolutely would second the recommendation to take a look at the policy platform. It's really, really incredible, and clearly so much work and research went into it. Yeah, and so speaking of defund, our next, so we're gonna move into like a Q&A panel portion of this. So if you have any questions for Katie or for Lauren or for Brandon, who I'm about to introduce, feel free to put those in the chat. But first, I just want to give Brandon a chance to introduce himself as well. He's a budget specialist, a union organizer, a voting rights leader, a racial justice advocate, and committed democratic socialist who's running for city council in Brooklyn's 39th district to win a people's budget that invests in the needs of all New Yorkers. So Brandon, if you would like to introduce yourself, please do.
Sure. Thank you so much for the opportunity. That list of descriptions, those are all the things that I am. But in reality, though, my career has been in voting rights organizing, so building power for Black and Brown people. And I tell people all the time that like Flint, Michigan is a democracy issue. So I think that like the democracy is really where people have power within all their communities, and it interconnects with all issues. But I also spent time as a budget analyst, and I think thinking about sort of what's affordable, what's within our budget, what's not within our budget, and how our city and state budgets are more documents is something that I think is incredibly important to think about, because we're trying to erase generations of racism that we've now through these presentations, all these things are incredibly connected, and I think that's an incredibly important thing to think about. So defunding the police, which is something that I'm incredibly committed to. I was part of the Occupy City Hall action. That work connects to the refunding of communities and the centering of communities' needs. And this is one of the best examples to talk about this, because even if we do defund the police, $3 billion goes only so far. It's like too little butter on too much of bread. Like we will be able to spread this out, but we have to have the New York Health Act, because there are so many other things that we need to fund within our community, and we need that work and that help from the state level. So there's a lot that we can do on that front, and it's incredibly important, but this connects to what's going on in the state. This connects to going on in different communities and building infrastructures. This connects to land use in terms of like how we're requiring that we build facilities and centers and clinics, in the developments that are going on around us. Just all these things are really meshed together in a really important way. So I want to underline that, and also just talk briefly about some interactions I've had that underline that as well. I spent several years part of a parole preparation project. So I was helping folks who are incarcerated come home, and get on parole. And I had spent a good part of a year helping someone who was over 60, who shouldn't have been in prison in the first place, but was there for 44 years, to just get his hip replacement It was through his multiple family members, following up regularly, calling, sending letters, a law student and myself who were doing this for an incredibly long time just to get a hip replacement that he was told he was going to get, and it never came. So this took an exorbitant amount of effort and energy just to get a person the justice that he was given or told to be given through our state. Clearly, there's no apparatus, and I feel that connects to everything that Lauren recently said about how that these systems are, and the racism inherently in them in terms of how people, don't get the care that they deserve. And, that's just something that stands out to me. And then also a few years ago, 5 years ago, my father passed away. And I truly do believe he had a stroke, but it was seen early. But I do believe he didn't get the right care. If he looked differently, he would have gotten better care. And something that was a small issue became a large issue, and he passed away because of it. And I will have the rest of my life to think about, if I said this to the doctor at this point, if I did that, how could he still be here? It's something that, is a cloud that's around me because I think about him every day. And I think that this is, the extent of how the trauma of how these systems fail people do follow people throughout their lives. So that's just something that I want to say. District 39 has a hospital in it and a hospital that's adjacent to it. These are things that a lot of people in my community are thinking about and talking about. So I just wanted to lift that up, and I'm happy to go on the next part of the program.
Yes, thank you so much. So I'm going to go ahead. Sorry, I'm going to be doing some Zoom pinning right now. So the next part of the program is just to have some conversation and to answer some questions. Thank you all so much for speaking. And if anyone has any questions, you can put them in the chat. Ivan, have there been any questions that people have put in so far?
I think we got one answered, and I haven't seen anything else. But if you do have a question, you should ask.
Yes, definitely. So please put your questions in the chat. I got a private message asking if Brandon is running for office, and yes, he absolutely is. He's running to be the next city councilor of District 39, and he's going to be fantastic at it. And yes, so Sandy, go ahead and unmute yourself if you'd like to ask a question.
Okay, thank you. It's easier to just speak it than to type it all out. So I have a question for Katie. Can you just explain a little bit more about the maternal health outcomes in more detail? So does that mean that the mothers are dying, the babies are dying, both are dying? Does that mean right at the time of childbirth they die? Or does that extend for like a year after birth? So it's the whole perinatal period. And can you talk about like, what are the main causes of death? Are they, losing blood and not getting transfused like they would if they were in a better hospital? Are they getting infections that they wouldn't get in a better hospital? Are they having poor nutrition that they wouldn't have in a better hospital? If you can just speak to all of this, because I just don't understand why it's so much worse in some of these hospitals than in other hospitals.
Yeah. Thank you for that question, Sandy. So I'll start with maternal mortality. So maternal mortality is very rare. So even right now it's on the rise in America, but even in that context, that means we went from 17 deaths per 100,000 live births to 23 deaths per 100,000 live births in the past couple of years, but that's measured per 100,000 live births. So it's a very uncommon event. And as you, kind of the things you asked, like, is it blood loss? Is it this? Yes, those are like, typically they are obstetric emergencies. And that so mortality is very uncommon. Morbidity is very common. So for people to have some kind of health issue during their pregnancy or during the labor and birth period, maybe 10% of birthing people will have some kind of issue that really requires medical intervention. So what we're seeing with the mortality and why it's so much worse in like why the disparity is so great in New York City is when those emergencies do happen, the the more dangerous hospitals and the hospitals that have been under-resourced for prolonged periods of time really don't have the resources to respond to that emergency quickly. So a very pivotal event in kind of what got me into health justice activism is because there were 2 maternal deaths in a 4-month period at SUNY Downstate in 2017. So like that is a total aberration, like to have 2 deaths in that short of a time at one place. And it is, it should be a total aberration, but is perhaps much more understandable when you look back and see that that was the fiscal quarter that Governor Cuomo had withheld our federal funding because he wanted us to get used to what it would be like to have less money in the future. So we were preparing for future budget cuts, and before the scheduled budget cuts came, Cuomo just kept our 2017 fall quarter financial payment in Albany. And the city hospitals sued him and got that money released, but SUNY Downstate is in this weird position because we're the only public hospital that's not a part of the city system. So the city hospitals got their money for that quarter and we never did. So as I was sending emails up the chain of command saying like, why do we have 7 nurses working a shift where we should have 15? Where are the other nurses? When are we going to get more staff? We should be transferring patients out of the hospital if we really can't get more staff to come in. And essentially like, A, we didn't have staff to even initiate those transfers. We were just like on skeletal, like on a skeletal shift for almost 6 months. B, we couldn't transfer our patients out because then we wouldn't even have money coming in for the next quarter, because that's how we get paid, is by providing care to patients. And we didn't have the money to even pay our normal staff because the money we thought was coming to us to pay our staff had been withheld from us in Albany. And so when a mother complained that she wasn't feeling well when she was visiting her children in our neonatal intensive care unit, it took us over an hour and a half to get her back to the maternity unit where her nurses were to provide her care, because the people who should have been, like the people who we called to say, hey, can you transport this mom back? There was no one working in that department that day. We called every 30 minutes, 3 or 4 times before this mother got transported back. And it was less than an hour later that she started to code. And when she did, they called the codes on the overhead 9 times. So like the whole purpose of a code is you call it once and all of the staff that you need to resuscitate the person come. Mm-hmm. The fact that they had to keep calling it every couple of minutes, almost over a half an hour, meant the doctors who should have been there to save her life never showed up to the code because they weren't working there because we were so understaffed. So like, it's not uncommon for women to develop complications, or it's not terribly uncommon for women to birthing people to develop complications while giving birth. That's why labor delivery units exist, is so that if and when they do, we are prepared to manage them. But if the doctors and nurses who should be working on a labor delivery unit aren't there, and it's essentially like a ghost hospital and it's essentially a ghost hospital, then yeah, like if the doctors don't show up when you call the code, people are going to die. And that is, if you look at 2017's numbers, like at least 2 of those mortalities were definitely preventable because they happened in a hospital that wasn't providing anything close to standard care. And that anything close to the care that was being provided to patients who were going to hospitals just a couple of miles away. So it's essentially like we would expect some amount of maternal morbidity at every hospital, but if you can't manage that morbidity, then it turns into a mortality. And the difference between whether or not you have the resources to intervene in an emergency depend on whether or not we're choosing to pay that institution a sustainable rate to have the staff and services necessary to provide adequate care. When it comes to infant mortality, that is a measure that's looked at essentially, any death before the first birthday. And so any death before the first birthday, and when we look at New York City, or the most easily modifiable factor we have right now in improving infant mortality rates is the difference in quality between NICUs. Most babies who get sick and die receive care at some point in a neonatal intensive care unit. More babies die inside of a neonatal intensive care unit than any other environment, just kind of given the premise that that's where we bring babies who are sick and require medical care. And so we have data that show that if Black babies were receiving care in the same neonatal intensive care units as white babies were in New York City, that essentially, if you pair them for gestational age and weight, all of the racial disparities in neonatal intensive care outcomes would go away. So 100% of the disparities when you pair babies by weight and gestational age is because of the different quality of care at NICUs. At SUNY Downstate, we were missing not only were we often working with half of the nursing staff that we should have had, and so that meant like sometimes babies didn't get fed. Like sometimes 6 hours pass and a baby would cry for 2 or 3 of those hours, and I just didn't do anything for that baby because there were other babies who would have died if I had it, like if I had gone to feed them. Like I cannot stress how desperate the conditions there were. And even on a day where we were properly staffed and we were able to do all of like the normal easy, of course you have to feed a baby when they're hungry for them to heal and get better and grow and survive. Even when we were able to do all of the basic stuff, we were missing a physical therapist, an occupational therapist, a lactation consultant, a social worker, like all of these specialties that, NICU cares only existed since like the 1960s, 1970s. And so a lot of what we know about how to help babies thrive if they require neonatal intensive care, we've only learned in the past 10, 20, 30 years. Well, New York essentially decided to stop paying Black serving hospitals at least 20 years ago. And so as other hospitals have learned new things and implemented those new technologies into their neonatal intensive care units, we're still practicing a style of medicine that's 30 years old. So our infant mortality rate is about what white neighborhoods' infant mortality rates were 30 years ago in East Flatbush. And it makes a lot of sense because the neighborhoods serving East Flatbush are practicing a style of medicine that's 30 years outdated. So like, yeah, of course you're going to get outcomes that were normal for that style of medicine if everywhere else is improving and these institutions can't because we've hobbled them through insufficient funding. This is how the structural racism, I guess this is what I'm talking about with the, we don't pay the hospitals enough. The hospitals serve an incredibly segregated population. So that hospital danger ripples out to create the population level health disparities.
Yeah, you gave a really clear picture, so that really helps me understand what's going on. So I'm just wondering, like, aren't there some kind of metrics in hospitals where they say, if you have for every 50 patients, there has to be, 1 doctor, 2 nurses, like, isn't there something like that? And then every hospital, regardless if it's in a rich neighborhood or a poor neighborhood, don't they have to adhere to those metrics?
So I'm so sorry to jump in. I think I'd like to keep this chat open for a little while after 7 if people are available. I do want to make sure, just because we were slated to end at 7, that if Lauren and Brandon, just to quickly ask if there are ways that people can get involved in Brandon, your campaign, or Lauren, the Defund campaign or other work with the Racial Justice Working Group, how people can be involved with those efforts.
Sure, I'll go real quick. Some people posted in the chat, westforcouncil.com is my website. We have to win if we're going to actually defund the police and spend funding on trying to reverse these systemic problems. That's the best way to volunteer and connect is on that website. Really appreciate it. Thank you so much.
Thanks, Brandon.
I'm not very good at this. Like we have like our website. I saw Tracy though. Is Tracy still here? Because I feel like she might be really good at answering this question. Oh, I don't see her. You should come to one of our meetings. for our working group, which you can find on NYC-DSA. Or you can also just email us, and I will put, I often answer the emails, as Alice knows. So, and I'll put that email in the chat. All right.
Thanks so much, Lauren. I don't know, Katie, if you have time to answer that question. I know, we're slated to end at 7, but go ahead.
So I'll just say, like, essentially public hospitals reflect the will of the public. And so if you're thinking like, oh, that's not how I want our public hospitals to run, please fill out the form, the organizing form that I've been dropping in the chat, because yes, you're right, there are regulations on how hospitals are supposed to work, and New York State knowingly pays SUNY Downstate less money than Downstate would need to meet the state's own regulations. So the state's paying the state-run hospital less than the state-run hospital needs to meet the state's regulations. And everybody in that niche circle knows that that's happening, and nothing's happening about it, essentially because people who work at Downstate feel like they'll lose their jobs if they bring attention to the missing specialties and the fact that patient care is poor as a result. And and the hospital came after me and I guess whoever wasn't worried for their own selves, I guess, were the people who'd come after you, because as I've done this advocacy work, SUNY Downstate did file a complaint against my nursing license on bullshit reasons to retaliate against me. So, it's the same thing. Like, we have laws to prevent insurance discrimination, and they don't work if we elect the guy who said we don't need to follow them to be our governor. And in the same way, like, we can create regulations for how hospitals should run. And if the public doesn't have the will to make sure the hospitals have the resources they need to meet those regulations, then we're kind of up a creek without a paddle. And as somebody did mention in the chat, there are while there are certain aspects of hospital care that are mandated that we're not meeting, that we should have laws that mandate specific staffing ratios. And if we had those laws, it would give us one extra avenue to pursue health equity at hospitals that understaffing is one of the main mechanisms of providing worse care. And that bill has majority similar to the New York Health Act, has majority support in the Senate and the Assembly. So when you call your people to ask them to, when you call the speakers to ask them to pass the New York Health Act, and when you call your personal representatives to ask them to prioritize the New York Health Act, you can add, also, while you do that, please prioritize the safe staffing bill. If those two things pass together, that would be fantastic from a health equity perspective.
Yeah, absolutely. I wanted to just quickly address a couple questions in the chat that were just about the New York Health Act and whether it could, basically whether providers would be treating people would be taking private pay, or would be rejecting people with the New York Health Act. I mean, it's basically we have models for public insurance that doesn't allow people to turn it down. I think what's excellent about a single payer system is it's basically the doctor's choice. It's possible that doctors could, try to take private pay, but if they want to have a regular patient load and seat, there's a lot of people who have totally free comprehensive health care, and they would need to be enrolled in that health care and follow that health plan's rules in order to do it. So I guess I just wanted to address that question quickly. I know that we are now over time. If Lauren or Katie, if you have, and Brendan had to head out, Lauren or Katie, if you have any final words before we leave. No? Okay. Well, thank you so much, everyone, for coming. We're having a panel on labor and tomorrow is a strategy meeting on labor organizing for the New York Health Act and a phone bank. So if you're part of, if you want to get involved in phone banking, on Friday, we're going to have a talk on how we're going to win this. Saturday, we're going to be in Grand Army Plaza and Prospect Park having a big canvas and party. And on Sunday, we're having a town hall featuring State Senator Julia Salazar. So all of that information will be at this link here. Yeah, and thank you all so much for coming.
Bye.